Hello everyone, very good evening to all of you. My name is Saurav. I am the head of marketing from Smart Oncology. Today again we are together in the same roof with esteemed panelists, esteemed faculty members with us. Today's Osmosis is on real-time case studies in prostate cancer as well as neuroendocrine tumor. We are talking about two different real-time case studies, and on that we'll be discussing today uh, with these two case studies. So today we have our program director, Dr. Devrat Arya sir. He's the principal medical director and medical oncology from Max Super Specialty Cancer Hospital, Saket, Delhi. We have our two esteemed moderator, Dr. Chandragowda and Dr. Sandeep Batra. Dr. Chandragowda is senior director and unit head from medical oncology, BLK Max Super Specialty Hospital, Delhi, and Dr. Sandeep Batra is our second moderator, who is Senior Director, Medical Oncology and Hemato-Oncology, Max Super Specialty Hospital, Saket, Delhi. With that, I welcome Miss Anjana. She is our from medical team, from medical affair team. She is going to talk some small few lines about our company. And with that, Anjana, you can welcome Dr. Chandagora as a first panel moderator to initiate the first panel discussions. Thank you.
Yeah, thank you so much, Saurabh. Again, wishing everyone a very good evening. I would like to welcome all the speakers, panelists, delegates, and Team Samarth. I am Anjana Yadav from the medical team of Samarth Life Sciences. On behalf of the organization, I am truly delighted to welcome you all for the today's webinar, which is Osmosis in Real World Cases. There will be two case presentation, as Saurav has already said. One is on prostate cancer and other is on the NET, where we will be discussing on the diagnosis, from the part of the diagnosis to detection and then the management. Now, let me tell you a brief introduction about what is osmosis. So Osmosis is basically a scientific initiative which is presented by our oncology division, OnQuest, which reflects the Samarth's continued commitment to advancing education and dialogue within the field of oncology. We believe that Osmosis is not merely a scientific platform, but also a powerful metaphor for knowledge dissemination, a network that connects ideas, expertise, along with innovation. So, before we start with the presentation, let me give you a small brief about the company. Samarth Life Sciences. Samarth Life Sciences is an innovative life science company that researches, develops, and manufactures as well as markets a broad range of life-saving products and other drugs. With our vision to emerge as an innovative premier healthcare company, we are committed to deliver healthcare products with the highest level of operational excellence. Now, it was invented in the year with the inception of Mr. Gunwant Lal Shah in the year 1963 and has been a prominent player in the pharmaceutical industry. Samarth Life Sciences operates through 14 therapeutic specialty division, each focusing on specific areas of healthcare. OnQuest is one of the division that take cares of the oncology specialty. We export over 250 products in over 70 countries, which demonstrates our global presence and commitment to serve the diverse market. With this short brief about us, we would like to initiate the scientific program. For this, I would like to introduce our program director, Dr. Devrat Arya, who is a principal director, medical oncology, Max Super Specialty Hospital, Saket, Delhi. As I already told you, today there will be two case presentation. So the first case presentation would be on, next please. The first case presentation would be on the real world cases on prostate cancer. And the moderator for this session would be Dr. Chandragowda sir. He is a senior director and unit head at Medical Oncology BLK Max Super Specialty Hospital, Delhi. And the panelist for this case presentation would be Dr. Sachin Gupta, sir, who is a director, medical oncology and hemato-oncology, Max Super Specialty Hospital, Mohali. Dr. Piyush Bajpai, sir, he is a director and unit head, medical oncology, Max Super Specialty Hospital, Dwarka, Delhi. Dr. Safalta Bagmar, ma'am, senior consultant and associate professor, medical oncology, Amrita Hospital, Delhi. Dr. Osin Suri, Consultant Medical Oncology, Shanti Devi Institute, Hisar. Dr. Osin Suri, due to some emergency, would not be able to join us today. So I am welcoming Dr. Chandra Gowda sir again, and over to you, sir.
So by that time, I think Dr. Devrat Arya is already joined. Sir, are you there?
Yeah, I was already here. I was here as a
Yeah,
delegate.
yeah. So So I already told because of some busy things that you were stuck out. So why not you can please welcome with two lines, because let's set a introductions and followed by Dr. Chandrakara sir can take it over. So why not you can please welcome with two lines, because let's set a introductions and followed by Dr. Chandrakara sir can take it over. So why not you can please welcome.
I'm sorry, there is some echoing going on.
Yeah.
तीन डिवाइस ऑन किया होगा उन्होंने 3 बार को हो रहा है
I'm sorry, there is some echoing going on.
Yeah. Again, there is some
डिवाइस ऑन
kind of
किया होगा
echo.
उन्होंने 3 बार को हो रहा है
It seems to have settled down now.
I'm sorry, there is some echo. Is it fine? Is it fine now?
3 बार को हो रहा है
It seems to have settled down now.
Sorry, there is some echo. Is it fine? Is it fine now?
3 बार को हो रहा है
So funny.
Seems to have settled down now.
Sorry, there is some echo. Is it fine? Is it fine? So funny. Kushi, please take care.
Yes, sir. Yes, sir. We are looking into it.
I hope it's better now.
Right, sir.
Yeah, it seems to be better. So I think some mix up with the joining link. But without further ado, I think our focus today is on prostate cancer and neuroendocrine tumor. And as we've already talked, I think in the past decade and a half with prostate cancer, seen how the paradigm has moved from predominantly hormone-driven treatment to a more molecular stratification of the disease. And we have seen how a modern clinician has to navigate between PSMA imaging, novel genomic alterations. But what we're also seeing is that even in the hormone sensitive setting, there's a lot of disease treatment intensification to improve outcomes. And I very quickly welcome Dr. Chandragoda to shed some light on our day-to-day clinical practice and how we manage our patients with advanced prostate cancer, particularly those who have castrate-resistant disease. So over to you, Dr. Chandragoda.
Thank you, Devrat. So I welcome my panelists, and we through this discussion we'll probably become more wiser. So the esteemed colleagues like Dr. Piyush, Dr. Sachin, and Dr. Safalta. So we'll just go from a non-metastatic CRPC and to a metastatic CRPC. Dr. Safalta, where do you see this non-metastatic CRPC in the current context of PSMA PET scan? Is it still existing, or it's not there?
So actually, we don't get to see. I mean, probably I have seen once or twice non-metastatic CRPC. It's quite rare. Probably the issue is, one is PSMA. We frequently use PSMA. Second is that usually they are with the urologist itself. So it's quite unusual to see non-metastatic CRPC.
Completely agree. So, Piyush, I mean, would you still just rely on only PSMA PET CT scan when the PSA is raising after some definitive treatment, or are there some scenarios where you will probably use a bone scan and other modalities?
Bone scan is something which is if a PSMA PET is available, bone scan is not something I would do. If in case it's inaccessible, you're talking about of accessibility versus inaccessibility. Of course, bone scan could be a fair option. Otherwise, if PSMA is actually available to us, then we would want to consider this.
Great. Dr. Sachin,
Until unless we are probably thinking that there is a loss of PSMA ability, that's in a high burden disease party.
Agreed. Sachin, any thoughts? Any different comments?
Yeah, Chandra, I think I fairly agree. You ask me?
Yeah.
Yeah. So we do see this, rising PSA, but no actual disease anywhere on the scan. So we do come across this situation. It is not that rare a thing also. And of course, we have some options of changing therapies and going to epilutamide, darolutamide, etc. And I would also rely on PSMA PET scans most of the times for such a situations. And until unless I have something else to do or suspecting neuroendocrine transformation, I may do, a normal FDG PET also.
Mhm.
And otherwise, by and large, we do PSMA PET scans only.
Yeah. Uh, Dr. Safalta, do you use a PSA DT as a strict, stringent criteria to start any of these the androgen receptor blockers, or you start irrespective whether the PSA DT is less than 10 months? Yes, we'll start any of these agents. So how do you select amongst these? Dr. Safalta.
Yes. I was just thinking of that. I don't follow this thing strictly, but yes, whenever there is a rise, I don't start it abruptly. I follow it for another 1 month, 2 months, depending on the symptoms as well. So, if at all there is a rising trend for 2 to 3 times, then I would like to start the treatment, not waiting for this 10 months now and non 10 months criteria.
Okay. Piyush, any different thoughts or any preference amongst these agents?
Well, dalatromide, if the patient can go for, especially these patients are elderly and cognitive issues, so dalatromide is a clear favorite from that perspective because of it can avoid subtle issues in terms of cognition and memory at times. Seizures, especially enzalutamide, is not to be considered over there.
Yeah.
In hypothyroidism, epilutamide. So basically, again, it boils down to what you look at in terms of side effects. You would want to avoid if the patient has a disease, confounding disease. And of course, the age of daratumide in terms of cognitive issues is there. But of course, it's an expensive option.
And would you start for each and everybody, or as Safalta was telling, you will just, even the PSA data is less than 10 months, would wait for some more months to see, or how do you decide about it?
So PSA DT, of course, less than 10 months is an important thing. So, of course, one would always want to recheck, as Dr. Safalta said. I mean, rechecking calling the patient again after a month is something that we all would want to recheck the lab, So, the urine routine and just recheck after a month. But of course, less than 10 months and these drugs available, we would want to start it. Of course, the other criteria are also there when we say that it is rising above 2 nanogram in terms if the radiation has been earlier given to the prostate. So that criteria is if the surgery is done and it is rising above that, and 25% increment above the PSA, the previous PSA value is something also which triggers the thought process. But of course, 10 months PSA DT is something that we all do look. We can always recheck another value in a month.
All right. So, Dr. Sachin, any comments from you?
Yeah, I think Dr. Piyush has fairly summarized it. So we need to see the rising levels. I also agree with Safalta, and I won't react that soon, especially if the patient is totally asymptomatic and fine and it is rising slowly. Maybe we can watch for a few months, and so getting something radiologically gives us more, it weightage to our change in the treatment plan. And but if it is definitely rising serially, the graph is going upwards, then we are supposed to change. And of course, we have some data from all these three drugs, and which we decide according to the cost also, and comorbidities, and also drug interactions. So
Now, again,
apalutamide is fairly
okay.
skin toxicity is there a lot of times. Enzalutamide cause lots of weakness in most of patients. So we have to individualize which agent has to be chosen.
Yeah. So now coming back to you only. So now we have a structural or radiological evidence of a disease of a CRPC. So how do you base your treatment in this particular setting? Or problem sequencing we'll talk about later. And then how do you say that yes, this patient needs to be on this particular only hormone, androgen receptor or chemotherapy? So how do you base your treatment?
So we need to see what has been used earlier in the first line, and what,
Yeah,
if patient is, historically, so most of patients have been on abiraterone or enzalutamide. So these two agents were available to us for quite some time now.
yeah,
And so we need to bring the other agent, and we have to see whether patient is eligible for docetaxel if not used earlier.
right.
Our patient is fit for receiving docetaxel. So sequencing would be according to what has been done in the first line, and then the disease volume and patient's age and performance status.
Right. So, I mean, you talk about what has been used earlier. Dr. Piyush, would you go ahead in the HSPC setting with the triplets, like, or which patients do you start, like P1 or Arsenic kind of approach?
So, HSPC, when it is a metastatic scenario, so yes, where it's a high risk HSPC or a very high risk HSPC, I would want to consider adding docetaxel. And of course, these are the places where I would want to consider. Burden of the disease does matter
Mm,
at baseline, but the sort of positive impact is seen in arrescence even in lower burden disease pattern also. Nonetheless, burden would be the thing which drives us more to act upon it, adding the triplet over there.
right. So, Safalta, your thoughts and then a role of, HRR now, or would you do it after failure of first line treatment?
Oh, first thing about the triplet regime, I fully agree with Dr. Piyush. And in according to for HRR, it is like it will be good to do it upfrontly because the data is coming up. Like if you want to add, if you are starting on abiraterone, you can add olaparib along with that, so that will help. And in BRCA1, BRCA2 patients, so I would like to do it upfrontly.
You want to do it upfront, so HRR.
Yes. Yes.
So also MSI as well, or you will preserve down the line, or you do it upfront? So it's very rare. I never found MSI high or
Mm.
deficient in any of my prostate cancer patients as of
So
now.
we can do it upfrontly also. See, the thing is that logistics will be good because you have the tissue, new tissue, 6 months. Because down the lane, you will not be able to get more tissue if there is bone metastasis. Getting bone biopsy done and putting all these things in the bone biopsy becomes difficult. And the tissue with the block you are having is getting older. It can be 1 year, 2 year, 3 years. So rather than that, you can do it upfrontly as well. So I would not be using immunotherapy upfrontly, but yes, olaparib I'll be using if it is HRR positive.
Now talking about the sequence, Dr. Sachin, if would you suppose patient is naive, he has not used probably just on ADT, and now he's progressed and there's definitely a high burden disease. So which do you prefer? A patient you start with only the androgen receptor blockers, or you just give chemotherapy upfront? So what's your thoughts on this?
So patient has received and this
Only ADT. He was an ADT and then
only
patient
ADT,
posted. Yeah.
no biratrone, no enzalutamide, nothing has
Nothing,
been.
nothing.
So look, so we have a choice here. So we need to bring one of these agents. So which will again depend upon patient's performance status, comorbidity. We have to choose between a biratrone and one of the things like enzalutamide, apalutamide, or darolutamide, right? So
Right,
these four agents are there with us right now.
right.
And of course, there is some cost difference and side effect profile differs. And according to the volume of the disease burden, we can bring in docetaxel, and patient's age and PS also matters here.
Right.
So we have good data with combination of docetaxel with darolutamide as well as with abiraterone. But if we
But that is
compare
in the
cross
HSPC
trials,
setting. I'm talking about
Yep, sure.
CRPC.
mm, yeah,
That's an
but
ars-
you know,
yeah,
again, these agents can be still combined
extrapolate.
in this set. Yeah,
Okay,
extrapolating from that.
okay.
So
So,
combine docetaxel, or we can use them sequentially also. But if the
mm,
disease burden is high, I would like to bring docetaxel here. And
okay,
since these agents were not used in the first line, in this,
yeah,
otherwise, you know, we would use for a metastatic castration sensitive prostate cancer,
yeah,
would be using doublet or triplet upfront also.
yeah,
But in this patient you are quoting, so it was not used. So here we have a choice of combining.
yeah. Okay. So, Piyush, your thoughts, and do we in CRPC when the SWOT node you can, do you agree that you combine both chemo plus androgen receptor blockers? Can't hear you. It's not there, so
Yeah, did you ask me, Dr. Chandra?
yeah, Piyush, yeah, Piyush.
Sorry, I could not get your question.
So, Dr. Sachin is, rightly extrapolating, saying that in HSPC we do triplets, and the patient in CRPC has only progressed on ADT. So, are you comfortable in using, if a patient is a high burden disease, combining androgen receptor blockers plus chemotherapy together rather than sequencing?
Again, it depends on. So you're talking about CRPC
CRPC,
setting.
correct, correct.
Well, CRPC, I think so. I mean, we would be tempted to use that data, but the triplet data is primarily for the HSPC setting, metastatic HSPC setting. Uh, so, if in case we are talking about CRPC, we really do not have what overall survival benefit we would get. We might get a good PFS, but sequencing would matter. So, I really do not have a perfect answer, but we
Yeah.
do get tempted to add upon it if in case the general condition of the patient is good. Also, it's a oligometastatic disease. So if in case we are talking about oligometastatic disease, so we now want to actually contain the disease with local therapies. So we would want to actually use the maximum therapies there. But as far as the data goes, it is primarily the triplet regime is primarily for the HSPC. And
Okay.
docetaxel, or for the CRPC, we have to consider this sequencing.
Safalta, your thoughts first, and then followed by if the disease burden is less, then how do you sequence? Do we start only the oral medications and then reserve and sequence later on? Later on, use the chemotherapy. What's your opinion on that as
So if the disease burden is less, in that case, I'll be starting either abiraterone, enzalutamide, darolutamide, depending on the age, frailty, comorbidities. So I will be adding oral therapy first, and then subsequently, depending on the disease burden, whenever there is a progression, in that case, I would prefer lutetium therapy first before going for chemotherapy. So that is one thing which I do in these
okay,
patients.
upfront.
After abiraterone and all, after using abiraterone,
Okay,
before even if there are frail patients who are still skeptical, like 80, 85,
okay,
and that age,
okay,
you
logical.
tend to,
Okay,
you can use lutetium therapy. The data has come up that it is better
yeah,
using upfrontly before
okay.
chemotherapy even. Yeah.
I mean, we have data, Dr. Sachin, saying that, like, if a patient is fit enough, even if it is a low burden disease, using chemotherapy upfront gives us better sequence and better overall survival overall, rather than using the receptor blockers or abiraterone upfront followed by chemotherapy. So, do you agree, Sachin, or your thoughts on this?
Can you rephrase your question?
Sequencing is very important in CRPC. If you
Yeah.
use the oral medications, be it receptor blockers or the enzyme inhibitors, so followed by chemotherapy, vis-a-vis starting chemotherapy followed by oral tablet. So we have a data saying that if you start the tablets first, that sequence has a survival is lesser compared to reverse sequence, like starting upfront chemotherapy, even if it is low burden?
Let's put the things into perspective. So the earlier situation was that patient did not receive any abiraterone, enzalutamide, or anything else.
Correct,
Patient was
correct.
only on, let's say, androgen blockade was there with
True.
your leuprolide, right?
Yeah, yeah,
So once patient becomes CRPC, patient is going to get all sorts of treatment at some point of time.
mhm,
So according to the situation, we have to decide whether we can try to control it in a much better way and for a more durable control is possible or not, for which docetaxel may be more helpful in certain situations, especially in, let's say, younger and more fitter patients. So
right,
that would give you some kind of, let's say, better PFS. And once we combine, once we go to the triplet thing, after finishing docetaxel, you may continue your oral treatment,
right.
which would continue for a longer time, and patient may remain in remission for a longer duration of time. That's what I meant.
Okay,
But
right.
if you have used, let's say, when the patient presents as metastatic CSPC, and there you are using triplet, then of course you will be using the agents which have not been used. Then you bring your HRR, olaparib, combining other things, and
Right,
later on in the natural history of the disease, you will bring lutetium and other
right.
radiation techniques.
Piyush, any thoughts about using cabazitaxel upfront instead of docetaxel? Which scenarios do you prefer cabazi, or you don't prefer at all?
I think so. The upfront, if I'm not wrong, I vaguely remember cabazitaxel upfront trial did not make a much of an impact.
But it
What
did not differ actually. I mean,
Yeah, it
there's
did
no
not
change.
differ
Yeah,
from docetaxel. I do not know about any docetaxel hypersensitivity scenario where we could probably use it. But otherwise, CART trial showed that you must consider cabazitaxel post docetaxel rather than keeping it, bringing the ARPI in between. So that's what I can say. Upfront cabazitaxel, I don't think so. It's not an easy drug to use
yeah.
anyways.
Yeah, so there are some thoughts saying that, yeah, in Safalta, have you used it in this particular
I
enough?
never used it, but then in up to date it mentions that
Yeah,
if the patient who is having poor GC and you want to use chemotherapy, then cabazitaxel is a better tolerated drug and that can be used. That's what up to date says, but I have never used and did not come across any of the data as well.
good. Your role on the radium or any sort of lutetium, other than the 85 upfront you use it. So otherwise, where do you place this? Safalta.
I would be using it after NHA, then chemotherapy, and then lutetium therapy. That's all. Radium 2 to 3, it will be like very low bone metastasis. That is the only way where I will be doing radium 2 to 3. That's it.
Okay. Dr. Sachin, if do you have any experience with Sipuleucel? We read it as a resident. I've never used it. Sipuleucel
Never
tea.
used. Never
Any?
used. I don't think I'm going to use it. It
Yeah.
was exorbitant. I didn't think the benefit was that great.
Okay. Yeah. So we know, especially as we are talking about the PSA, the velocity, or it is very, very low, or low burden of the disease, when you can try it. Uh, Piyush, Safalta, do we have any experience of using Sifuleucel?
Not at all. No.
Okay.
I
Not,
think it
no.
was oversold. This drug was projected to be something great, but
Yeah.
this technology, and we don't have experience because it was too costly.
Right.
Otherwise, we could have tried in some patients at least, because these patients would, and they would always progress and they would require certain different kind of treatments. But because of cost issues, I think we could never use it.
Right. So I mean,
What about dendritic cell vaccine? Any?
so I was about to come to the other that questions. Dendritic
Dr.
cell.
Chandragowda, another panelist should have been invited here.
So Devrat, dendritic cell.
I haven't used it.
Nobody has used it. Nobody will officially use it.
I have not used it unofficially either.
Yeah, okay, right. So I think we have discussed all these points, selecting the first line treatment in MCRPC. In the second line, sequencing agents we have discussed with all the experts, the emerging role of targeted therapy, and a role of NGS. Dr. Safalta, Dr. Mosmi is also there. So have you got any new targets in the prostate?
No.
No.
So
Okay. So
we
same
have
old thing,
been
PARP.
doing, yes, same old.
Okay. So PARP and some MSA. These are the only things. Sachin, I mean, have you got any NGS weird report saying that this is the one which you can, and you use that particular drug where you don't think to use in prostate cancer? Has something like that have come across? Dr. Sachin, followed by Piyush.
I don't think so. I don't recall using something different. So beyond PARP inhibitors and immunotherapy, maybe once only I tried. I don't recall too many situations. I didn't get any good answers in NGS as well.
Okay. Piyush, any of your experience? Some
So,
unusual thing in NGS?
no, so I mean, I have seen not exactly the particular mutation, but then it is said that retinoblastoma mutation, even if the morphology is not small cell, you could probably use cabazitaxel and carboplatin metronomic doses to actually, or carboplatin metronomic doses, if I'm not wrong,
Okay.
where you could get a good PFS
Mhm.
basically. So more of a behavior of a small cell would actually be there. I have used, I mean, my carboplatin and endoxin, a
Yeah.
few of those patients, metronomic, have done pretty well. So uh,
Where do you
sometimes with the
place?
mix and match of the phosphestrol, this
Okay.
Honman.
Where do you place endoxin? I usually probably when a patient is on abiraterone and the PSA is rising and the PSM is rising slightly, not much, and the PSM PET is normal. So that I probably add endoxin. So would you do the same thing, or which other scenarios you added?
No, it is only after the exhaustion of therapies, as you rightly said, that when you are
No, I'm
going
not
out.
talking about exhaustion of therapy. So I have not used chemo as of now. Patient is on abiraterone and slight range in, or any of for the androgen receptor block for that matter. So, but slight PSA is increasing the PSA infection is normal. Would you consider endox? I've done few cases.
Okay, okay.
Yeah, with at least some PF. I don't know. I don't have a comparison to say, but at least the PSA comes down a bit and it stays there for some months. Dr. Sachin.
Yeah, Chandra.
So आपने किया? So we have done this kind of thing or anything that is unusual that we can learn from and probably implicate that thing.
So we have used these agents. So beyond Enza, Epa, darolutamide, docetaxel, cabazitaxel, and PARP inhibitors and immunotherapy.
Okay.
And Honven for Festrol is a good
Yeah.
drug.
Yeah, I agree.
When other things don't work, then Honven
First,
works
true.
in some of these patients. That should not be forgotten.
Absolutely.
So that becomes, a good savior.
True.
Uh,
Completely agree.
Beyond this, nothing. I don't think there is any other exciting agents which I have used or which has given any benefit.
Right. Dr. Safalta, your final comment. I think I've finished my 25 minutes and we covered all these topics.
So I have never used any of the unusual drug in prostate cancer. Uh, mm, Once I tried to use etoposide and cyclophosphamide combination, Pepsi sort of
Okay.
combination,
Right.
but it did not work.
Okay. Thank you all. Thank you, Piyush, Dr. Sachin, and Dr. Safalta for nice insights and thank you, Sam, for giving us knowledge. Thank you, Devrat. With that, I think we covered all this. Don't want to just go further and show you all the slides. So just finished uh, with the topic. Thank you very much.
Thank you
Thank
so
you,
much,
Dr.
Dr.
Farah.
Chandragowda, sir, and all the panelist members. It was an excellent and insightful case presentation, and indeed it was a very comprehensive and engaging discussion. Now I would request Dr. Devrat sir to have few words on the case study on the prostate cancer, and then we will move on to the second case presentation. Dr. Devrat sir.
Yeah, so thank you, Dr. Chandragowda, for the wonderful discussion and all the panelists, in fact, on understanding the nuances of management of advanced prostate cancer in the modern setting. And now we change gears, neuroendocrine tumors, a very different lens. We see significant heterogeneity across grade differentiation, somatostatin receptor expression, increasingly molecular drivers, although I don't think we, still practice a lot of precision oncology there. But there are systemic options. There is PRRT now. I think I'll not take much time. I'll invite Dr. Sandeep Batra, who's a respected senior at the place where I work, a mentor. So over to you, Dr. Sandeep Batra, to discuss some of the nuances of management of this very heterogeneous disease in the modern context. Over to you.
Thank you, Dr. Devrat, for the nice introduction and kind words. I hope I am audible. I will briefly open my video. I'm still on my way to my home, so probably some network issue might be there. Can I call my panelist, or and if someone from Smart, thanks, Smart.
Yeah,
someone
I'll
can,
call sir. Yeah, I'll call sir.
Yeah, please upload the presentation also.
Yeah. Khushi?
Yes, ma'am.
Okay. So the case two presentation, the panelist for the presentation, the case presentation are Dr. Vikas Goswami sir. He's a senior director medical oncologist at Max Super Speciality Hospital, Vaishali, Ghaziabad. Dr. K.M. Parthasarthi, director and senior consultant medical oncology, NH Dharamshila, Delhi. Dr. Ishu Gupta sir. He is a consultant medical oncologist. Cancer Center, the Daycare Center, Delhi. Dr. Atul Sharma, sir, Associate Director, Medical Oncologist, Max Super Speciality Hospital, Noida. Khushi, can you please share the slides?
Yeah, sure, ma'am.
Yeah.
So we have Dr. Atul Sharma sir, Dr. Vikas, Dr. Parthasarthi, and
Ishu Gupta, sir.
Dr. Ishu. Okay, thank you.
My screen
Thank you.
visible?
Yeah, it's visible.
Yes, it is.
Thank
Okay.
you. Thanks,
Yeah,
ma'am.
welcome.
So can we
Over to
move on
you,
to the
sir.
case? Yeah, thank you. Can we move on to the case? So we'll be discussing gastroenteropancreatic neuroendocrine tumors after the excellent discussion by Dr. Chandragowda. So in the interest of time, we will not take much time on the history, just to brief. This is a 45-year male who presented with abdominal discomfort and vomiting in February 24 with weight loss, found to have gastric outlet obstruction. A CT abdomen done showed a pancreatic mass with liver mets, underwent a duodenal stenting to help him eat and to bypass the gastric outlet obstruction. Barium swallow showed mild gastric holdup or contrast. Please move to the next slide. Please move to the next slide. So EUS guided FNAC, previous one. So EUS FNAC and the liver SOL biopsy and pancreatic mass EUS FNAC. Okay, so they did it from the liver and the pancreatic mass, which was positive for malignant cells. On ISC, the tumor cells suggested that it is a clear-cut case of a neuroendocrine tumor with a Ki67 of 1%. So final opinion was well-differentiated neuroendocrine tumor, grade 1. Next. So this was the old classification that we used to follow and still is ingrained in our minds. Low grade, intermediate grade, high grade based on the Ki67 and the number of mitosis. Less than 2 to 20, more than 20, easy, well differentiated, intermediate or moderately differentiated, and poorly differentiated or neuroendocrine carcinoma, and there has been a change in this classification. Next slide, please. So they divided the grade 3 into well differentiated, and the Ki67 was again more than 20 based on the histology, and the small cell types or the large cell type neuroendocrine carcinoma with the high Ki67 into separate categories from NET grade 3. So one question I would like to ask, let's start with Dr. Atul. Dr. Atul, sir, you are still following in your practice the old classical ingrained, because that was quite a useful classification, and this is a little bit more complex with no significant difference between the treatment or management of the grade 3. So are you following the old classification, or you are looking into the new classification and deciding treatment accordingly?
Sir, I am Dr. Atul from Noida.
Okay, no worries. आप तो हमारे लिए सर वैसे भी हैं. Dr. Atul, so are you still
Sir,
following
sir-
the old classification or the new one?
Sir, we try to incorporate the new also, because there are subtle changes, as you said, that the grade 3 has been further divided. So we take call based on whether it is high grade, poorly differentiated. So these patients, I think, are candidates for they are aggressive disease, so they are candidates for chemotherapy. We do consider the new classification.
Okay, so that means pathologist input about the well differentiation versus poorly differentiation, you take into cognizance,
Yes.
and based on that you decide. Quite fair, quite fair. Next slide, please. So a dota PET was done, which showed the mass was involving the head of pancreas, abutting duodenum, with a stent, which was already done, and there was some lymph nodes. Liver showed few dota avid lesions. SU max was 19.2. So in the pancreas, it was 25.7. In the liver lesions, 19.2. So Dr. Vikas, in the scans, right now we have a dota neck over here, neuroendocrines. Do you see into the SUV values like we used to see earlier in the FTG PET scans? High FTG means more rapidly growing, fast growing tumors, aggressive. Low FTG avid means less aggressive. Do you see the same thing in the neuroendocrine tumors? Does the SGV correlate with the differentiation, grade 1 or maybe grade 2 showing SUV high and the vice versa? Is Dr. Vikas there? Okay, so Dr. Partha, can you dwell on this question if Dr. Vikas is unavailable or not able to take this question?
I don't think they closely reflect the thing like FDG PET. My treatment
Okay, they
decisions
don't.
are not based on the uptake.
Okay, and that triggers my second question. Very right. What about the sandostatin LAR, octreotide LAR? Does SUV correlation that your disease might be controlled only with the these drugs, or you need to add something more to the standard sandostatin, the octreotide LAR, based on the DOTA avidity?
That depends on the tumor bulk and the how much the patient is symptomatic. If you want a rapid response, I start with the LAR with everolimus, two drug combination. If it is a somewhat indolent disease, slow growing, tumor burden is less, then I start with somatostatin LAR alone.
So what about this patient, young patient, tumor burden you have seen, you have a pancreatic mass causing gastric outlet obstruction, there are few liver lesions, some lymph nodes. What do you think? Only doing based on this DOTA-PET SSTR versus SSTR in combination with everolimus or something, or is there any chance of doing a limited surgery in the form of cytoreduction in this patient?
There is data of limiter surgery also, but if the patient has got a gastric outlet obstruction, either you have to do a stenting or a bypass surgery, and that might be a
Stenting has
symptom
already
reduce.
been done. Stenting is already done.
Tumor debulking as such,
Okay.
unless the patient is very much symptomatic about the disease, though there is data, even 90%, now there is data about even a 70% reduction. just to alleviate the symptoms. There is data for that, but right now in this patient, surgery can be deferred.
Okay. So you rightly said we have to assess the biology of the disease. Since patient was obstructed, stenting has been done, he is able to eat, and you have a grade 1 well-differentiated neuroendocrine tumor, so you can manage it with the SSTR plus minus some other drug. Move to the next slide, please. Next slide. So this was the data. You can see the pancreatic lesion, the liver lesions, and the pancreatic lesion causing the gastric outlet obstruction. Next slide, please. And you can see a stent also in between. Next. Now, Dr. Partha already said that octreotide LAR or senotriptan LAR or the similar drugs, that is the SSTR, anti-SSTR therapies. And we have already discussed the surgery can be an option when you need a rapid debulking when the other conservative approaches fail. So, has Dr. Vikas joined back, or we move on to Dr. Ishu? Dr. Ishu, in this patient, grade 1 neuroendocrine well differentiated, octreotide LAR versus observation versus surgery versus PRRT. Which will be your favorite choice, or any combination?
Sir, observation I would not take in this patient. The patient already had symptoms of a GI
Very
obstruction
right.
which were relieved by stenting. Definitely the
Very
patient
right.
needs therapy. Surgery,
Okay.
since we have relieved the symptoms as of now, the patient is now out of the GO, so not right now, obviously. Then comes up PRRT. It's a, as you said, it's a Ki-67 of 1, if I remember.
Yes, it is 1%.
So even in the Netter 2, that's the upfront PRRT, the Ki-67 needed to be high for taking these patients to be on the upfront PRRT. I would take this patient on octreotide LAR.
Octreotide. Very right. Anyone in the panel who differs that only octreotide LAR may not suffice, or if someone wants to put the PRRT in the first line plus minus octreotide LAR? Dr. Partha, Dr. Atul, any difference in opinion, any different thoughts?
Sir, grade 1, low Ki-67, I think good expression of SSTR. I think we should initially try standard-statin LAR only.
Okay. Agreed. So this patient, next slide please, probably would have received, it's not my case. Thanks, Murth, for giving this case to me. So this patient underwent octreotide LAR therapy. Next slide please. So this is, these two slides next will be just showing the benefit of adding the SSTR antagonist, that's octreotide LAR. Next slide please. This data we have already in the form of PROMIT trial, and that I've seen there is a progression-free survival difference and a minuscule OS difference also with these drugs. Next slide. Won't dwell much on this, and you can see the curves. Those with high volume disease versus low volume disease, the survivals and the control of the disease are better with the low volume, and that incidentally also tells us about the aggressiveness or biology of the disease. Next slide, please. Okay, so this patient was started on octreotide and asymptomatic. So May 24 he was started. Let's see how he progressed. Next slide. So we have agreed that only single agent octreotide LAR is to be given. Next. So it's almost about 7-8 months, December 24. Response assessment was done, which showed there was some response, and that's more in the decrease in the SUV from 19.2 to 11.9 in the liver, and from 25.7 to 16.2. And structurally, there was decrease in the size as well. Next, and there were no new lesions. Next slide. So obviously, everyone in the panel agrees that patient is on right path. We don't need to tinker with the treatment. We continue with the octreotide LAR. Any different thoughts? Dr. Ishu, Dr. Partha, Dr. Atul, and if Dr. Vikas is there, do you think that since we have got a sufficient control, we should add on something in the form of oral, intravenous, or something like PRRT to increase the response?
So I think
I
patient
think we
is
should
not.
continue the same, sir.
Yeah, I think patient is doing
Right.
fine. We should continue same, because addition of therapy will add toxicities as well.
Right. So since it is a stable or partially responding disease, we continue with the same. So next, after about 9 months, he was scanned again, and there was further decrease in the DOTA ability as well as the size of the lesions. Next. So I think September 25. So this patient has almost now got nearly 1.5 years of treatment, and it's a continuing this response. Suppose we do a next scan in January 26, and there is a stable disease. Are there any takers of stopping the octreotide LAR?
The patient is not having any symptoms, disease is under control. So I think we should continue. He is responding to therapy. I think we should continue the same.
So there is no endpoint to octreotide LAR. It has to be continued till the time patient is responding, partial response or stable disease. Now I bring a twist. Not talking about this patient. Suppose the patient has progressed on octreotide LAR and you are contemplating a change of therapy, be it addition of everolimus, be it adding PRRT. Octreotide LAR will be continued or discontinued?
Sir, in case I add PRT, I discontinue octreotide LAR.
You discontinue. Okay. So, Dr. Atul? Oh, Doctor, sorry, you are. Dr. Partha?
I am continuing unless I am using a cytotoxic regimen. So we are adding everolimus in my day-to-day practice. Sandostatin is continued.
So till the time any cytotoxic is as it, you will continue. What about, as Dr. Atul said about the PRRT? If he goes for PRRT, he stops octreotide LAR. Do you practice that? This patient on progression, octreotide LAR almost about 18 months. Now you are contemplating PRRT. Continuation of octreotide LAR, yes or no?
Now in the study, octreotide is discontinued, and if you are using lutetium, then lutetium alone will suffice.
Okay. Any difference of opinion by anyone else?
Sir, I usually tend to stop octreotide LAR.
tend to stop.
There is that saturation of receptors, just in case, octreotide is already doing it. PRRT is also going to bind to the SSTR receptors. We do stop it about 4 weeks approximately before the PRRT cycle.
Okay, so that is the case when the disease is already being controlled. Once there is a
Correct.
progression,
Once,
and you are contemplating
yes.
PRRT, will you continue or discontinue octreotide LAR?
Sir, I have been discontinuing based on that Netter one. I think
Okay.
they also did not continue it in the second line. It was a study PRRT versus octreotide, if I am not wrong.
Okay.
That's how I have been doing it. But yes, there is logic to continuing it if the disease is progressing. Definitely, receptors are not saturated.
Okay, fine. I think there are a little bit of variations. Some people continue even beyond progression, irrespective of using cytotoxics or PRT. Some people say that since the disease is already progressed and the classical thinking is, except for few exceptions, most of the times, if the disease has progressed on the treatment, it's time to change the treatment. Anyhow, it's more on the experience based and based on the interpretation of the trials and data. But I think everyone is true to their opinion. They have their right of opinion. I most of the time in practice continue with the octreotide LAR because I think the disease biology may become mixed and there might be misrepresentation or heterogeneity of the tumor samples when you take the biopsy, and there may be some element of response to the octreotide LAR. Anyhow, everyone is right in their opinion. Next slide, please. How frequently you see this carcinoid syndrome? I think I can barely count on the fingers the carcinoid syndromes that I have seen and managed. How frequently you see this carcinoid syndrome? Anyone? Any takers of that question? Dr. Atul, Dr. Partha, Dr. Ishu,
Sir,
Kas?
it is rare only. I think there's one patient I had seen which after both the octreotide and PRRT progressed and eventually started developing it in due later course rather than in the early course.
Okay, in later course, when the disease is becoming uncontrolled and creating
Yes,
these symptoms because of the release.
the patient did have uncontrollable diarrheas. She needed
Okay,
octreotide every 2 to 3 hours, short acting. But
short-acting octreotide. Okay.
yeah, but not a good disease in the end. So yeah.
Okay, so instead of using the short-acting, does the increasing the dose of the long-acting agent, like from 20 to 30 or 30 to 60, does make a difference in controlling these symptoms?
Yes, we did try going up to, from what I remember, 60 milligrams every about 15 to 20 days is what we were giving. I looked up
Okay,
some data. There was some data on giving it more frequently. We did it, but it did not help. What helped the
did not
patient
help.
was the short acting.
Okay, besides short-acting, any other intervention? Next slide, please. I think they have mentioned some drugs, although I have not used any of them. So SSA high dose is somatostatin analog is high dose is off label, but as you said, I have also used, but it fails to make a significant difference. By 4 to 6 weeks, the effect is gone. Then they have SSA plus telotristat, SSA plus IFN alpha, chemo. I think debulking surgery. Everyone has tried every type of things. So I think anyone has an experience of using any other thing than increasing the dose of somatostatin analogs. We don't have lanreotide over here. So that's what we do is increase the dose of octreotide earlier, and that usually there is a tachyphylaxis and the response is lost very soon. Let's move to the second slide. We have next slide. We have other cases as well. Okay, so case 2 is 58 female presented with typical upper GI symptoms. Ultrasound showed there were bilobar liver lesions. PET CT showed there was lesion in the stomach. So I think this scan was done before the biopsy really came in. FTG avid mid body of stomach, perigastric gastrohepatic nodes, peritoneal deposits, bilobar liver lesions, mild free fluids, tumor markers except for CA125, which was mildly raised, were normal. Next slide. So biopsy was done from liver surface and it showed well differentiated neuroendocrine tumor grade 2, synapto and crimo positive, Ki67 50%. So finally labeled as grade 2 NET. Next slide. Next slide, please. Okay, so after this NET grade 2 came in, they went for a DOTA PET. Previous slide. Previous slide, please. So they did a DOTA PET and so we have a previous FTG PET. No, please go to the next slide in which we have a DOTA PET. Yes. So we have now a mild wall thickening in the mid body with heterogeneous uptake, with DOTA avid, all those things that were there in the FTG PET scan, but now they are DOTA avid. And when they compared the avidity of the FTG PET with the DOTA PET, the deposits had more FTG uptake as compared to the DOTA uptake. And serum chromogranin was 67.4. So this raises a question before we jump to the management. How many of you are doing the dual PETs, dual tracers, FDG PET as well as DOTA PET in your neuroendocrine tumor patients? Let's start with Dr. Partha.
I'm not practically doing that unless if I'm thinking about the pace of the disease, if it is going into a kind of small cell transformation or something like that. But now there is data that you will pick up more lesions if you combine with the FDG PET, even in the lower grade also. But I am not practically doing that.
Okay, so I'm telling you a real life practical problem. Suppose this patient had a FTG PET, final biopsy is NET grade 2, and you have decided to start the treatment in the form of guidelines of NET grade 2 with the SSTR antagonist with or without everolimus. Now, at the start of treatment, will you keep the FTG PET as a baseline or you will order a DOTA PET for the future comparisons?
No, if you are doing both at the baseline, then you have to do.
No. FDG PET is already done.
Mhm.
You have got the biopsy report later. It's a NAT grade 2, and now you have decided to start with octreotide LAR plus minus everolimus.
Mhm.
And now will you do at baseline DOTA PET or not?
If it is a grade 2, then you should do it Dotanac also.
So that means every grade 2 you should do both the things, DOTA as well as FDG.
If money is not a criteria, otherwise we have to do a practical. Yeah.
So okay, scientifically, if we do, then that means you agree if we have a grade 2 tumor, ideally we should combine a dual tracer uptake, FDG PET as well as DOTA PET. But I think many of us are not practically doing it because it's a cost which is associated. If FDG is already done, subsequently we start treatment for NAT, and subsequently we try to compare the DOTA scan after 3-4 months with the FDG PET scan. Am I right in my thinking, Dr. Partha?
Now, DOTA has to be compared only with the DOTA.
No, we compare the CT component. Obviously, DOTA is to be compared with DOTA,
Yeah.
but patient has already done FTG PET and doesn't have sufficient finances. You have the biopsy, you start the treatment, and 3-4 months down the line, you do DOTA. You compare the CT component of the two. Obviously, you cannot compare the DOTA SUV with the FTG SUV.
Yeah, that is a practical solution. Yeah,
that's a practical.
A middle way.
Sir, we recently had a patient where it was a grade 2 neuroendocrine tumor of the rectum, and there were lesions in the liver which were only picked up by FDG PET CT. The DOTA PET was not showing any lesion in the liver. So he got an MRI for the rectal lesion because previously it was thought that it is a adenocarcinoma rectum. So surgeon got a MRI rectum, and the uppercuts, there were some lesions in the liver were reported. Later on, the histology came as grade 2 neuroendocrine. So we were, very much confused, and this is similar situation because if you see the DOTA scan, then this patient had a localized disease only. But if you consider FDG PET, so he had liver lesions. So, and then the lesions were biopsied. The grade in the liver lesions were higher as compared to the Ki-67 was higher in the liver lesions as compared to the rectal lesions. So I think it is not common, but we will definitely get such a few odd cases in the practice. And I agree.
Right. So,
if cost is not an issue, then we should do both.
Yes. So you have hit the hammer directly at the point where it was needed. So whenever you have a grade 2, so it can be a heterogeneous presentation. So it's better to go for a dual PET, and whatever is the type of PET which has got more findings, you should continue doing the same PET in future, provided finances are a challenge. If finance not a challenge, then ideally dual PET both the times. So whenever doing the response evaluation. Let's move on to this case further. It was interesting. FTG PET was done before the biopsy. After biopsy, DOTA was done. And that's typical representation of real life, how it happens in some of our cases. Next slide, please. So he was started on octreotide LAR. And when subsequently after 4 months, the DOTA was done. So there was some increase in the disease. So again, Dr. Ishu, if you can tell, was the clinician who was treating held on the underside of the treatment by not offering everolimus at that point because it was NAT grade 2? It was both FTG and DOTA avid. FTG was more avid than DOTA. Retrospectively, in the hindsight, everyone is wiser because we are seeing that subsequent scan there was some increase. So would you have, if you would have treated this patient, you gone only with the octreotide LAR, or you would have added everolimus to this patient? Hello? Hello?
Yes, sir, you are audible.
Yes, sir.
I'm audible, na? So
Right, sir.
anyone from the panel, if they can respond. We have overshot the time. Okay? No, I think still we have
It is
about
better
5
to
minutes.
add octreotide to the octreotide.
It was better to add everolimus to start with. Fine. So anyhow, there are durustat. So they started it later on. Everolimus was added, and someone tried repeat biopsy to understand what's happening. NAT grade 2, 16%, Ki-67, continued on octreotide LMS. Next, please. Next slide, please. So there was some response to treatment with residual disease showing mild decrease in size of mental nodules. So probably the combination worked. No other somatism. So octreotide everolimus continued. Next scan. Next scan, please. Okay. Next, someone again did the biopsy, and now the Ki67 is 23%, grade 3. Next slide. Let's see how the scan was showing. So there was some increase in the lesion, and someone started with the Cape Town. Okay. So, Dr. Partha, you are visible to me on the screen, the others are not. So I will come back to you again. So in the neuroendocrine tumors, with the type of heterogeneities there in the presentation, diagnosis, treatment, what do you think? Treatment is more of evidence-based or treatment is more of experience-based? Or it's a judicial mix of both the two things?
There is no ideal sequencing of treatment, but once you are exhausted with your everolimus, PRRT, Sutent or cabozantinib, then I usually go to the cytotoxics, and my choice is Captam.
Fine. So I think if Ki60 is into grade 3 or the poorly differentiated type, but if it is less than somewhere 50, less than 50%, we go for Cape Tam. It's something more than 50, we think of intravenous chemotherapy. Is that right, Dr. Partha?
Yeah, I use etoposide and platinum-based chemotherapy when Ki67 is above 30.
Okay, fine. So suppose this patient had some progression. We did not do the Ki60 was originally 18%. I presume that remained the same. The FTG ability was lost as well as the DOTA ability was lost, only some structural increase in the disease. How many in the panel would offer PRRT to such a patient having failed on octreotide LAR as well as everolimus? In the absence of DOTA ability of the tumor, how many of you would be comfortable going for PRRT therapy? I think we'll briefly answer this question rapidly and then wrap up this case.
Sir, I think this patient is not an ideal candidate for PRRT therapy.
Not an ideal candidate. But so
progress, rapid tempo of the disease, high Ki67, low expression of SSTR. I don't think this patient is going to get benefit with PRRT.
Right. It's time that if the Cape Tam fails, then move on to the intravenous chemotherapies. Try doing a repeat biopsy, send it for NGS, find out if it's something better than what we can do classically. Next slide, please. Next. So again, grade 3 and high grade, the chemotherapy works. Grade 1 and 2, to some extent in grade 2, Cape Tam may work, but DOTA is not very strong. Next slide, please. Next. So patient was continued octreotide LAR. I think Cape Tam was started. Probably he responded. And when he fails, it will be time to move on to chemotherapy intravenously. And PRRT may not help. And if finances permit, NGS and further treatment. Next slide, please. Okay. So as we have already discussed, there are many different treatment options, but there is no optimal sequencing. It's mix of judicial, mix of experience as well as the evidence. And multidisciplinary team. And there are no standard predictive factor response, and it's an urgent field. And with this, I will thank all of my panelists for their active participation and scientific discussion. Hand over back to Smarth and Dr. Devrata. Thanks once again, all of you.
Thank you so much, Dr. Sandeep Batra, sir, and along with the panelist for such an insightful and comprehensive case presentation. Now, I would request Dr. Devrata, sir, to for the concluding remarks.
Yeah, so I think very, very interesting case, and thank you, Dr. Sandeep, for bringing out the gray zones that we often face on our day-to-day clinical practice. I think what this meeting also underlies is the fact that when we are treating patients with such advanced cancer in the real world setting, you not only balance evidence, but you also look at biology, patient fitness, access, increasingly long-term toxicity considerations. So I think meetings like this are very good opportunities to question evidence, collaborate, personalize care, and I think just to highlight, we do repeatedly realize and understand that real world oncology does demand real world decisions. So thank you, all of you, all the moderators, all the panelists, for your participation, for your excellent discussions, and back to Samarth.
Thank you, Dr. Devrat, sir. Thanks for the concluding remark. At the same time, we are happy today that Mr. Arvind is there with us, who is our country manager. He will give in the vote of thanks, and after that, he will wrap up the sessions. Thank you.
Thank you, Saurabh. Good evening, sir. And on the behalf of my entire oncology Samarth team, I would like to extend our sincere gratitude for the excellent and insightful medical sessions. And a special thanks to Dr. Devrat Arya sir for his leadership and guidance as a program director, and to Dr. Chandragowda sir and Sandeep Batra sir for their highly informative and engaging presentations. We also sincerely appreciate and thankful to our eminent panelists, Dr. Piyush sir, Dr. Sachin sir, Dr. Safalta ma'am, Dr. Vikas sir, Dr. K.M. Parthasarthi sir, and Dr. Atul sir, and Dr. H. Gupta sir for their valuable perspective, thought-provoking discussions, and active participation, which greatly enriched the session. Sir, your expertise, practical insights, and interactive approach made this session extremely valuable and impactful for all participants. We truly appreciate your time, efforts, and commitment to our academic excellence. We look forward to continue collaboration and much more such impactful and scientific program in future. And in the last, sir, once again, we are grateful for your valuable time and efforts. Thank you. Thank you so much, sir.
Yeah. So with that, I'd like to wrap up the sessions with saying that today we have an audience of 120 live attendees. They're enjoying the sessions. They're getting the insights from you through these scientific sessions. Thank you, everyone. Good night, and have a wonderful way forward. Thank you.
Thank you.
Thank
Bye.
you
Thank
so
you.
much, everyone. Thank you.